Karuna, final. Good afternoon, everyone. Myself, Rama Tripathi, Senior Dietitian, SGPGIMS Lucknow, wants to share you some views on clinical and dietary approach on diabetic nephropathy. So nowadays, diabetes is a very common problem, especially in youngsters. So you can say, according to WHO, diabetes is a growing challenge in India with estimated 8.7% diabetic population in the age group of 20 and 70 years adults. It is basically an endocrine disorder in which the body's ability to produce or respond to the hormone insulin is impaired, resulting in abnormal metabolism of carbs and elevated level of glucose in the blood. So there are three types of diabetes. One is type 1, next one is non-insulin dependent diabetes, that is called type 2 diabetes, and one is gestational diabetes. There are secondary diabetes also, that is because of some drugs or chemical inductions, or because of any steroids or genetic defect of beta cell or insulin. Now comes on pathophysiology of diabetes. As you are seeing in the slide, first picture shows the normal metabolism of glucose. As you are seeing, the healthy pancreas, or inside the healthy body, pancreas secreted the insulin, and that is around properly, you can say, absorbed by the cells. Now, on second picture, that is a type 1 or autoimmune diabetes, insulin not produced, that means no insulin to unlock the receptor glucose cannot enter the cell, glucose re-enters the bloodstream, blood glucose level rise. And the third picture, that is type 2 diabetes, insulin is produced, but there is less, and there is a decrease in the number of receptors, that is insulin resistance. Glucose doesn't enter the cell effectively, glucose re-enters the bloodstream, and blood glucose level then rise. Now comes on the components of diabetes mellitus. There are so many components, but basically there are 5 components to manage the diabetes. Especially one is overall monitoring of everything, then the drug, or you can say pharmacological therapy. One is awareness or education, and one is nutritional management, and the most important thing is exercise also. So this is the triangle of diabetes management, that is basically diet, drug, and exercise. So there's 3 components basically by which we can management any kind of diabetes of adults. So who are at the risk? Now the risk factors basically is obesity, ethnicity, or you can say the race, history of cardiovascular disease, hypertension, physical inactivity, family history, or polycystic ovary syndrome, that is PCOS, or gestational diabetes. Now the complications of diabetes mellitus, so there are 2 types of complication. If the acute phase, then there is a diabetic ketoacidosis, insulin shock, hyperglycemia, or you can say non-ketotonic coma or dawn phenomena. In a chronic scenario, there is a nephropathy, that means damage and obliteration of capillaries supplying the kidney. Next one is heart disease, that is myocardial infarction from the atherosclerosis, and other is skin changes, that is diabetic dermopathy, and last one is liver changes, that means enlargement and fatty infiltration. This is the table of insulin. I think you should know about the type of insulin and the preparation, peak duration or maximum duration. But that is purely depends on the on your clinician advice. So don't go to self-medication related to insulin. So there's rapid acting, short, intermediate, long analog, combinations, and combinations of analogs. That depends individual. Now comes on glycosylated hemoglobin. As you know, nowadays every clinician or every prescribed prescription, you are seeing the HbA1c. So what is exactly the HbA1c? HbA1c is a test that measures the amount of glycated hemoglobin in your blood. Glycated hemoglobin is a substance in RBCs that is formed when blood sugar glucose attaches to the hemoglobin. And when you saw the HbA1c report in any kind of prescription, so you must know about the you must know about the last 3 months glucose level of any individual. Now, especially what exactly the dietary management for the diabetic adults. So the major thing is we are following individualized 3 meals, 2 snacks schedule diet plan. So that means balanced diabetic diet, or you can say balanced diabetic food for any adults. So that in that balanced diet, 50 to 60% calories from the carbohydrates, 25 to 30% of calories from fat, and 50 to 20% of proteins of the total calorie of any individual person. So diet, but basically the diet based on patient size, weight, age, occupation, activity, and the region which he or she belongs. So do not skip meals. Advise use of complex carbs to help stabilize blood sugar. Meals should include more fiber and starch and fewer simple or refined carbs. Avoid concentrated sweets, high in sugar, for example, jellies, jam, cake, mithai, or etc. Avoid periods of fasting and feasting that is strictly followed by any individual. Keep weight at normal level. Obese diabetics should be on a strict weight control program and should lose weight. And avoid processed, canned, or bakery items. Now, how you determine the adult dietary calorie or overall requirement of any individual calories? That depends basically on activity factor. If the adult is obese and if he or she is sedentary, then we can give 20 to 25 kilocalorie per kg ideal body weight. And if the activity level is moderate, then the 30 kilocalorie, and he or she involves in strenuous physical activity, then the calorie should be 35 kilocalorie per kg ideal body weight per day. Now, for the normal adult, the normal weight of adult, if the weight is normal for the person, then for sedentary lifestyle worker, we should prescribe 30 kilocalorie per day. For moderate, we should advise 35 kilocalorie, and for strenuous activity, we should advise 40 kilocalorie per day. For underweight or severely underweight patients, we are used to, for the sedentary lifestyle, we are used to 35 to 40 kilocalorie, for moderate 40, and for strenuous activity, we try to advise 45 to 50 kilocalorie per kg ideal body weight, but that purely depends on it. My practical advice to all of you that we should try to individualize focus of any individual diabetic adults. So we can increase the calories according to individual scenario. Now, the determination of desirable body weight, there's a basic Humvee formula we are using for that. And if the frame is small, then we subtract 100%, and if the frame is large, then we add 10% of the total weight. The calculation of daily calorie requirement, the basic Harris-Benedict equation determines, and till date, it's the best equation to determination of your total daily energy expenditure or calorie. The BMR formula uses the variables of height, weight, age, and gender to calculate the basal metabolic rate. This is the basically formula for individual men and women. After calculating this, you can add 300 to 500 calories for weight gain, pregnancy, lactation, and subtract 500 calories for weight loss in obesity. This is the stress factor we are using for the this scenario. For elective surgery, that is 1. For multiple bone fracture, that is 1. And accordingly, you can use this stress factor for any specialized individuals. Now, components of the diabetic diet, as we elaborate in our initial slide, that means carbs up to 55 to 60% of total total calorie of per day requirement. That means, and the sources of this carb should be bread, vegetables, fruits, dairy products, or rice also, little amount of rice also. For protein, approximately 50 to 20% of total calories, and recommendation, or you can recommend it to 0.8 gram per kg ideal body weight of adults. Fat should be 30% of total calorie, but you can accommodate according to patient weight also. We are using for this kind of person step 2 diet. That means saturated fat should be restricted to 6 to 8% of total calories. A reminder should be supplied in monounsaturated fats. Cholesterol is less than 200 milligram daily on a daily basis, fiber up to 40 milligram daily basis, and sodium depends on individual, like 1000 milligram sodium per 1000 calorie, not exceed 3 gram on a daily basis. This is a case. This is a case history. One person have a body weight of 50 kg, height is 160 centimeter, and the diagnosis is type 2 diabetes mellitus, hypertension. The person is vegetarian, and the HbA1c is 6.5. That is borderline. For that case, we should prescribe at least 30 to 35 kilocalorie per kg per day. Protein should be 0.8 to 1 gram per kg per day ideal body weight. Visible fat should be 25 to 30 gram per day. Dietary fiber should be 30 to 40 grams, and sodium basically 3 gram per day, and cholesterol is less than 200 milligram per day, basically from step 2 diet. This is we just put a picture of traditional Indian diet. That should be, we should try to follow this kind of diet on a daily basis. Now comes on diabetic nephropathy. What is diabetic nephropathy? If the person suffering from diabetes, there is a three type of triopathy, you can say. That means one is diabetic nephropathy, one is diabetic neuropathy, and one is cardiopathy also. So now you are seeing the picture: protein in urine, secretion of protein. When the patient have suffering from the diabetic nephropathy, then there is a protein leakage in the urine. So India, among all the SAARC countries, has become the diabetes capital of the world. 20 to 40% of type 2 diabetes patients having microalbuminuria progress to overt nephropathy, that is diabetic nephropathy, and equal to or more than 20% progress to ESRD, making it the leading cause of ESRD in the past 2 decades. So diabetic nephropathy is characterized by albuminuria, which is usually accompanied by hypertension, progressive rise in proteinuria, and decline in renal function. This is how the diabetes affect the kidney. So physiology of kidney, and everybody knows it filters blood. It works as a glomerular filtration, tubules secretion, removes toxins, regulates extracellular homeostasis, acid-base balance, electrolyte balance, fluids, blood pressure control, secretion of hormone, erythropoietin, renin, and vitamin D3. This is the anatomy of kidney. And this is how kidney functions inside our body. This is the pathophysiology of diabetic nephropathy. How diabetic nephropathy, if the person suffers from the diabetic nephropathy, this is the pictorial diagram. Now comes on epidemiology. 63% of patients with diabetic nephropathy have type 2 diabetes mellitus. The risk of developing diabetic nephropathy is not constant over the duration of diabetes. 40% of dialysis cases of ESRD are diabetic nephropathy. 45% of patients will have microalbuminuria after 5 to 10 years of onset of type 1 diabetes. 50% of the cases of microalbuminuria end up in ESRD will need renal replacement therapy for survival, and this is the picture of normal kidney and diabetic kidney. And what is the exactly risk factor? So the major important factors are genetics: high blood pressure, hyperlipidemia, smoking, long-standing diabetes, and pregnancy. So the genetic, if you want to define genetic factor, that means person having family history of diabetic nephropathy is more likely to develop it as well. Inadequate glucose control, improved blood glucose level has found to reduce the risk of nephropathy. High blood pressure usually it occurs as a result of kidney disease, but it is also associated with progression and pathogenesis of nephropathy. Hyperlipidemia, smoking, long-standing diabetes. Patients having long-standing diabetes have higher risk of developing nephropathy. During pregnancy, there is a risk of GFR which returns to normal after delivery, but hypertensive women or those with renal disease prior to conception have higher risk of progression of the disease. This is the risk factors. Basically, one is diabetes, high blood pressure, heart problem or stroke, obesity, family history, tobacco uses or smoking, or 60-year plus age. Most risk factors are modifiable. That means preventive healthcare models need to be supported. That means male gender, duration, smoking, hypertension, inflammation, hyperglycemia, and obesity. Now, what exactly the symptoms of diabetic nephropathy? So, the major or you can say the first important symptom is nausea and vomiting, then the tiredness, loss of appetite, edema, bubbling in urine, itching, shortness of breath, or nocturia. So this is the comparison of normal with declining function of the kidney. So normally kidney removes of nitrogenous waste products, fluid and electrolyte and acid balance, blood pressure control. It involves an excretion of certain drugs, production of erythropoietin, and formation of 1,25 dihydroxy vitamin D. But when the kidney function is declining, then there is an increasing pattern of serum, blood, urine, nitrogen, and creatinine, fluid and sodium retention, and increased serum potassium and metabolic acidosis, raised blood pressures, alteration of drug activity, decreased production of erythropoietin and hence red blood cells, and lead to anemia, and HbA1c would always be low. Decreased calcium absorptions also. This is the stages of kidney diseases, that is stage 1, 2, 3, 4, 5. That depends on the glomerular filtration rate. There is a formula. GFR is equal to 140 minus age into body weight per kg into 0.85 if female, and 72 into serum creatinine milligram per dl. Using an estimation equation for the GFR, that is the authorized estimation of eGFR. How to explain, and this is how we explain the GFR results of the patient. I mean, normal is more than 60 ml per minute per 1.73 m square, and if the kidney disease is there, then there is 15 to 59 ml, and if the kidney failure, then less than 15 ml per minute per m square is the GFR. Now comes on stage 1, that is very early diabetes, stage 2, that is developing diabetes, stage 3, that is over or dipstick positive diabetes. I mean, in stage 3, GFR damage has progressed to clinical albuminuria with GFR 30 to 59 ml, basement membrane thickening due to AGA, the urine is dipstick positive containing more than 300 milligram of albumin in 24-hour period, and hypertension, that is high blood pressure, typically develops during stage 3. Now stage 4, GFR, glomerular damage continues with increasing amount of protein albumin in the urine. The kidney's filtering ability has begun to decline steadily, and blood, urine, nitrogen, and creatinine has begun to increase. The GFR decreases furthermore with HER 15 to 29 milliliter per minute. Almost all patients have hypertension at stage 4. Now stage 5, that means ESRD, end stage renal disease or chronic kidney disease. In this scenario, the GFR has fallen to less than 15 ml, and for that patient needs to renal replace therapy, that means hemodialysis, peritoneal dialysis, or kidney transplant is needed. Goals of medical nutrition therapy, the management therapy of diabetes nephropathy. That means sufficient in proteins, adequate in calories, restrict in sodium, potassium, phosphorus, and fluid, especially in dialysis. So amantine is an important role for the prevention of diabetic nephropathy. That means maintenance of near normal blood glucose levels by controlling food intake and exercise, achieving optimal serum lipids and blood pressure to reduce the risk of CVD, management of body weight, maintaining biochemical parameters and fluid status, prevention of long-term complications, prevention of malnutrition and strategies to control diabetic gastroparesis. Prevents and treat protein, energy malnutrition and mineral and electrolyte disorders, improves patients' outcome, minimize the impact of other comorbidities on the progression of kidney disease. So, medical history, then diet history, anthropometric measurement, biochemical parameters and nutrition requirements, it all comes in a medical nutrition therapy. An important marker of good diabetes therapy is that blood glucose is maintained below the renal threshold, that means 250 milligram per dl. So that is not passed into the urine. Insulin resistance and glucose intolerance are characteristic features in patients with the kidney disease. According to American Diabetic Association, after 5 years of diagnosis of diabetes mellitus, microalbuminuria must be tested annually, as it is also associated with the elevated HbA1c levels. The target HbA1c should be less than 7%. This is the summary of diabetic management of the patient with diabetes kidney disease. That means the proteins is 15% of total calories, or RDA of 0.8 gram per kg per day and per ideal body weight. For the patient with DKD, carbs should be specifically recommended, according to individuals. Fat is also according to individual diet history or weight and activity level, and sodium should be 1.5 to 2.3 gram of sodium per day. This is the pyramid of this is the diabetic kidney disease pyramid that also elaborate the PUFA, MUFA and fatty acids. Now, patient-centered care, that means what exactly the nutrition, sodium-rich food is avoided because we need to blood pressure control. We need to avoid sugar or sugar-based product for the glycemic control, and we need to exercise for overall control of the lipids and sugars. And what exactly individual choices of the patient, so we try to consider it for any kind of nutrients. So now comes in a sodium reductions. More sodium comes from the processed and restaurant foods. You can say in this graph that means 77% of sodium comes from the processed and restaurant foods. 5% is from home cooked food, and while eating we are use table salt, that is the percentage that 6%, and natural occurring is 12% of sodium in overall our foods. This is the case if the body weight is 80 kg, height is 164 centimeter, the serum creatinine level is 2.4 milligram, hemoglobin 11.5. Sodium, serum sodium should be 135, potassium 4.5, calcium and phosphorus is so, and urine protein is +3. Then we give the energy is 30 to 35 kilocalorie, protein should be 0.7 to 8.8 gram, plus 3 gram of proteinuria, that is leaked from the urine. Total fat should be 25 to 30%. For total calorie, dietary fiber should be 20 gram per 1000 calories. Sodium should be less than 3 gram per day. Potassium 1 milli equivalent per ideal body weight. Serum phosphorus should be 800 to 1000 milligram per day. Calcium should be 1500 milligram, and cholesterol should be less than 200 milligram per day. Phosphate binders are a must to be taken with meals. Folic acid and iron supplements are a must, but that is with the clinician's advice. So now comes on a myth, because there are so many myths for the diabetic kidney patients. So first myth is kidney patients should say no to proteins. Strictly no. Over restrictions of protein leads to protein energy wasting, and that leads to be fatigue or severely malnourished to the patient. Now, no salt or low sodium salt is good. Low sodium salt have high potassium content, which is not good for the kidney or heart patient, because that is also contains sodium and other minerals also. So that is not overall good for the patient. Third myth is drink lots of water in kidney diseases. So fluid intake should be according to how much urine patient passing out and exactly what kind of activity you are doing, like you are doing a moderate activity, you are involving in strenuous activity, or you are or your lifestyle is a sedentary. So that all depends on the basically your fluid intake, your per day urine output plus your sweating things. Third myth is one shouldn't drink fluid as I have kidney disease. Don't restrict your fluid intake unless advised by your doctor according to your physical condition. Now the next myth is kidney patient can only take boiled food. No, never. Condiments and spices have a very good kind of immunity effect. So that can be taken in a limit. They have anti-inflammatory and antiseptic properties also, and that enhances the taste that is required by the patient. Kidney and dialysis patients should quit the job, have rest all day. It is purely a myth. It must remain, the patient must remain physically active and should involve themselves in their normal routine of work without overexertion. I have now the next myth is I have anemia. I should increase my consumption of pomegranate, red meat, liver, and spinach. I am seeing in my ward that if somebody is admitted in kidney disease ward and some relative wants to meet him or her, they are they bring basically pomegranate, juices, etc., because there is a myth. Then when they eat it, their hemoglobin level should be increased. So these food items should may increase your potassium or creatinine level. So try to consult the doctor for iron supplementation and any kind of potassium related supplement, because that depends on totally your serum potassium or serum iron level. Next myth, I am not frying or eating oil because I have dyslipidemia. So many oils are rich in healthy fats and are essential to meet the patient's energy needs. So that depends on the area and the activity of the patient. I feel tired, I will eat more proteins and drink protein shakes. Exceeding allowed patient protein intake will increase the stress of kidney. So try to go to your or try to meet your clinician or your dietitian for the specifically planned diet for your specific problems. I can eat not allowed food on the same day of dialysis. Always follow your prescribed renal diet on all the days. So try to meet your registered dietitian, especially for the changes or for any changes or any anything you want to eat it for. So for that you need to consult your dietitian. I'm allowed 40 gram protein per day, which means I can eat only 40 grams of chicken or fish. 30 grams of chicken is equivalent to 1 meal serving. It has 7 grams of protein. So 40 grams of protein means it is to overall per day meal protein requirement. So that will be calculated by the dietitian. So try to keep in your mind that this is not the proper way to take your diet, especially if you are suffering from the kidney problems. I have nausea, and when I smell cooked food, I'll exclusively eat legumes instead of meat, chicken and fish. So take guidance with your dietitians about this idea also, because your ideal protein requirement and type of protein, as eating only legumes might raise serum potassium and phosphorus levels. So keep how you can keep your kidney happy. For that you need to fit and active. Try to regulate your exercises or physical activity. Keep regular control of your blood sugar level, monitor your blood pressure, eat healthy and keep your weight in check. Maintain a healthy fluid intake, do not smoke. And do not take over-the-counter pills on a regular basis. That means self-medication, try to avoid. So thank you, keep your kidneys healthy And thanks for give your valuable time to listen our this lecture. Thank you so much.